He said it in front of 3 people, loud enough that the nurses at the station heard it, loud enough that the man in the next bed went quiet. I don't need someone reading from a checklist. Call someone qualified. She didn't react. She finished writing on the chart, set it down, and left the room without a word. And I watched her go, and I watched him lean back with the particular satisfaction of someone who has just demonstrated something about himself that he believes is worth demonstrating. I had known men like him my whole career. I had, at certain points, been a version of him. What happened over the next 3 weeks changed something I could not name until it was already done. The tattoo was the last part, but it was not the most important part. I need to explain what kind of ward it was before I explain anything else, because the environment shapes everything that followed. Ward 7 at Landstuhl was not a general recovery unit. It was a specialized post-operative ward for returning special operations personnel, SEALs, Rangers, MARSOC, a few others whose designations I wasn't entitled to ask about. The men who came through it had been through things that didn't translate easily into the standard patient experience, and the staff who worked it understood that. Or most of them did. I had been a Navy SEAL for 11 years. I had rotated through 3 deployments in Afghanistan, 1 in Africa, and 2 training assignments that I am not going to specify further. I was 34 years old, and I had, in the course of those 11 years, broken my left arm, 2 ribs, and my right orbital bone, had shrapnel removed from my left thigh on 2 separate occasions, and had developed a relationship with physical pain that was, I would say, functional. I understood pain as information. I did not enjoy it, but I did not catastrophize it. The injury that brought me to Ward 7 was a collapsed lung and significant internal damage from a vehicle incident during an exfil. Not combat, technically. The vehicle hit something in the road, and the door came in on my side, and several things that were supposed to be interior became briefly exterior. The surgeon who worked on me said it was the kind of injury that was approximately 50-50 for about 40 minutes and then went one way. It went the right way. I was there for 3 weeks of post-operative recovery before I would be transferred stateside. The ward was 12 beds, usually occupied by 8 to 10. We were not an easy patient population, and I say that without pride. It is simply accurate. Men trained to suppress pain and distrust dependency do not make cooperative hospital patients. We were, most of us, too accustomed to control to relinquish it gracefully, too conditioned toward self-sufficiency to accept assistance without some internal negotiation. The nursing staff managed us with a kind of practiced patience that I respected even when I didn't acknowledge it. They had heard every variation of "I'm fine" from men who were clearly not fine. They had learned to read the difference between discomfort we could manage and discomfort we were performing the management of. I was, I believe, a middle-tier patient in terms of difficulty. I did not refuse medication. I did not attempt to leave before I was cleared. I asked questions and expected direct answers, and when I received anything other than direct answers, I asked the question again. I was not aggressive. I was precise, which in that context had some of the same social effects as aggression. The man in the bed beside mine, I will call him Carver because that is close enough to his name, was not a middle-tier patient. He was at the far end. He was a SEAL, senior to me by 4 years in service, and he wore his rank like weather. It was simply always present. He addressed the nursing staff in the tone of someone accustomed to being the authority in any room he entered, and in his professional context, that was probably accurate. In a hospital ward, it was something else. I had met men like Carver dozens of times. In some respects, I understood them. The difficulty of setting down the identity that had organized your entire adult life, even briefly, even for the purpose of healing. When you have spent years being the person who assesses and decides and directs, being a patient feels like a costume that doesn't fit. You keep pulling at it. But there is a version of that which stays internal, which is understandable, and there is a version that gets directed outward, which is something different. Carver directed it outward. I had been in the ward for 4 days when the new nurse arrived. She came in during the morning rotation, was introduced briefly by the lead nurse. Her name was Keller, and began her rounds without ceremony. She was methodical, quiet, efficient. She had the movement pattern of someone who had learned to work in confined and chaotic spaces, which I noted without analyzing it further at the time. Carver noticed her too. I watched him watch her, and I recognized the specific quality of that attention, and I knew before anything had happened that something was going to happen. I simply didn't know yet what it would cost him. Her name was Lieutenant Keller. Christine Keller. She went by Keller with the staff, which suggested a prior military context, though I didn't press it. The first morning she ran rounds on our end of the ward, she came to Carver's bed before mine. Standard rotation. She was moving through from the far end. She introduced herself, asked the standard questions, checked the chart. Carver answered in monosyllables and watched her with an expression that I had learned to read in the field as evaluation, the specific look of a person deciding what category something belongs in. She made a note on the chart, asked if he'd been managing the breathing exercises. "I've been doing them," he said. "The chart shows they were completed once yesterday," she said. Not accusatory, just factual, the way someone states what a document says. Carver looked at her with the expression shifting. "I did them more than once." "I'll update the record," she said, and moved on. It was a small thing, unremarkable, and yet something in the exchange stayed with me the way small things do when they contain a density that you can't immediately account for. She had not challenged him. She had not capitulated either. She had simply stated what the record showed and offered to correct it and moved on. I noticed he watched her back as she went to the next bed. She came to me after. I was in the middle of the ward, so I had time to adjust my impression of her from the brief interaction I had observed. She was, up close, younger than I had initially thought, late 20s, possibly 30, but there was something in her manner that read older than her features. The economy of her movements. The specific way she looked at you when she asked a question directly without performing ease or performed competence. She simply was competent, and the directness was a consequence of that, not an affect. She asked about the pain levels. I gave honest numbers. She asked about sleep. 4 to 5 hours, I said. Fragmented. "That's consistent with where you are," she said. "It should improve in the next week. If it doesn't, we'll look at it." I appreciated the specificity. Not it'll get better, but it should improve in the next week. And if it doesn't, we'll address it. There was a difference, and she was, I thought, someone who understood the difference. Over the next 2 days, I watched Carver's relationship with Keller follow a pattern I recognized. Each time she came to his bed, he found something to take issue with. The timing of the medication rounds, the way the chart was formatted, the information she relayed versus what he expected the senior physician to tell him directly. Each individual complaint was within the range of plausible patient concern. In aggregate, they were something else. She absorbed them the way a good structure absorbs load, distributed, without visible stress response. On the third day, she asked him about a change in his vitals overnight. He told her it wasn't her area to assess. She said evenly that monitoring post-operative vitals was within her clinical scope and that she was asking a standard question. He told her to leave it for the doctor. She made a note and left. I lay there in the half-light of the afternoon and felt something that I can only describe as a specific kind of discomfort. Not on her behalf exactly, or not only, but the kind of discomfort you feel when you watch something being done poorly in an area where you know what competence looks like. When someone is dismissing a tool that is working because they have decided in advance that the tool is beneath their requirements. I had served under 2 commanding officers who did that, who decided based on factors that had nothing to do with performance that a particular person's contributions were not worth incorporating. In both cases, it cost the mission something real. I was not on a mission. I was in a hospital bed with a recently reconstructed chest. The stakes were different, but the pattern was the same, and I found I could not watch it without registering what it was. That evening, Keller came by for the last rounds of the day. She checked my chart, asked one question, and left. Carver didn't say anything that time, but the way he watched her leave suggested that a decision was building in him. I had seen that look before, too. It happened on a Thursday. I know the day because I had been tracking my recovery against a rough internal timeline, certain benchmarks by certain days, and Thursday was the day I was supposed to begin low-level breathing resistance exercises, which I had been looking forward to in the limited way that people in recovery look forward to any sign of progression. Keller came in that morning with the respiratory therapist, a civilian woman named Dowd, to walk me through the exercise protocol. It was a routine process. They did it for every patient at the equivalent recovery stage. They went to Carver first, as was the rotation. Dowd began explaining the exercise. Carver listened for approximately 30 seconds and then said, with a quality in his voice that I had heard building for days, "I was doing resistance training while you were in school. I don't need the basics." Dowd, who had the professional composure of someone who had seen variations of this interaction before, said mildly that she understood, and that this protocol was specifically calibrated for post-thoracic surgery and was different from standard respiratory training. Carver looked at Keller. "Is she the best you have for this, or should we call someone qualified?" He said qualified the way people say words they've chosen carefully to hurt. Keller looked at him for a moment. Not a long moment, but a moment that had substance. Then she said, "Nurse Dowd is exactly qualified for this. We'll complete the assessment." And she turned back to Dowd and nodded, and the session continued. Carver did the exercises with the specific compliance of someone who is complying in order to demonstrate that the activity is beneath them. I watched all of this from my bed and said nothing. Afterward, when they came to me, I did the exercises and paid attention and thanked them when they left. Dowd seemed briefly surprised by the thank you, which told me something about the tenor of the ward in general. That afternoon, I found myself thinking about the phrase Carver had used. Someone qualified, the implication being that the person present was not. And I found myself turning over the question of what had actually made him believe that, what information he had used to reach that conclusion, because I had been watching Keller for 6 days by then. I had watched her catch a medication dosage discrepancy that the overnight chart had missed. I had watched her notice a change in the man at the far end of the ward and flag it for the physician before rounds, and the physician had adjusted the treatment accordingly. I had watched her conduct every interaction with the professional precision of someone who had developed their competence in an environment that demanded it. What Carver had not done, as far as I could observe, was watch any of that. He had made his assessment on the first day. He had found something, her manner, her age, the fact that she did not present herself with the kind of performed authority that he understood as competence, and he had made a category decision, and the category decision had been the end of his actual observation. That evening, I asked the lead nurse, a veteran of the ward named Sergeant Moss, how long Keller had been posted here. 3 months, Moss said. Where did she come from? Moss looked at me with the specific look of someone deciding how much information is appropriate. She transferred in from another assignment, he said. Overseas? A pause. I believe so. She has a particular way of moving, I said. Like she's worked in constricted spaces. Moss looked at me for a moment that was slightly longer than a normal conversational beat. She's very good, he said, and then he moved on to the next task, which was a clean redirection if I'd ever seen one. I lay there and looked at the ceiling. She's very good. Not, she has excellent credentials. Not, she came from a strong program. Just, she is very good, said with a quality that meant something more specific than the words themselves. I thought about the way she moved. I thought about the way she had absorbed Carver's dismissals without reaction, not the careful calm of someone managing their response, but the settled calm of someone who had been in environments where that kind of statement was not the most difficult thing in the room. I did not know yet what I was looking at, but I had started to look. The incident on Friday was the one that changed the visible shape of things. Carver had been cleared for supervised ambulation, short walks in the corridor, twice daily, with nursing support on the first few sessions. It was standard protocol. Most patients at that stage were eager for it. The immobility of recovery is its own particular burden, and movement, even limited movement, represents a forward step. Keller came to assist with the first session. Carver looked at her when she arrived and said, "I'll wait for someone else." She said, "I'm the nurse assigned to your care this morning." "Then reassign," he said. There was a quality in the room, a specific stillness that happens when something has been said that cannot be unsaid. The man in the third bed was awake and not looking at either of them in the deliberate way of someone who is paying careful attention. I was paying careful attention. Keller said, "I'll let Sergeant Moss know you've requested a different assignment for this session." She left. Moss came in 15 minutes later, conducted the session himself. Carver walked the corridor in the quiet satisfaction of someone who had gotten what he asked for, and I watched this from my bed and felt something I can only describe as a slow, cold recognition. Later that day, Moss came to check my chart. I asked him, quietly, if there had been any formal complaint. "Nothing formal," he said, "but informally." Moss looked at me with the steady, neutral expression of someone who has worked in high-pressure environments long enough to have a very good poker face. He's expressed some preferences about his care assignments, he said. And we accommodate what we can accommodate, he said. Patient satisfaction is part of care management. I thought about that formulation. Patient satisfaction is part of care management. It was accurate, and it was also the kind of accurate statement that can be used to justify almost anything. Is Keller being reassigned off his case? I asked. There's some discussion, Moss said carefully. I didn't say anything else. I didn't feel it was my place to say anything else. I was a patient, not a supervisor. The ward had its own chain of management and its own considerations that I was not entitled to override with my opinion. But I felt the specific weight of watching something unjust proceed through legitimate channels. The reassignment, if it happened, would be documented as a care accommodation. It would be processed as a routine staffing adjustment. It would not be recorded as what it actually was, which was a senior person using the passive authority of his rank and his presentation of expectation to remove a competent professional from his vicinity, because he had decided she did not meet his undefined threshold for qualified. And Keller would have no formal recourse, because no formal wrong would have been recorded. That evening, I was watching the window when Keller came in for the late chart review. I said without planning to, I want to apologize. She looked at me. For the environment here, I said. You've been doing your job well. What's happening with the patient beside me is not a reflection of your performance. She was quiet for a moment. Not the quiet of someone searching for a response, more the quiet of someone deciding what to do with an unexpected thing. Thank you, she said. That's not something you need to manage. I know, I said. I wanted to say it anyway. She nodded and finished the chart and left. I thought about that exchange for a while afterward. She had not used the opportunity to express grievance or invite solidarity or make me complicit in her side of whatever dynamic was in play. She had accepted the statement and redirected cleanly. It was, I thought, the behavior of someone who had learned to carry her own weight without handing parts of it to people around her. That skill is not developed in comfortable environments. Reassignment was confirmed the next morning. Keller was moved off Carver's primary care assignment. A different nurse was rotated in. Carver was visibly satisfied in the specific way of someone who has exercised a mechanism and found that it works. I looked at him across the beds and thought about what I had observed over the past 7 days. I thought about the medication discrepancy she'd caught, the patient she'd flagged, the session she'd run with more precision than the circumstances required. I thought about Sergeant Moss saying she's very good in that particular tone. I thought about the way she moved. Something was still missing, but I could feel the shape of it. The conversation happened by accident. Or not by accident exactly. It happened because I was in the corridor on my 4th supervised walk, and Keller was at the nursing station writing notes, and I had been thinking about what I wanted to ask her for 2 days, and I decided that the corridor at 7 in the evening was as good a place as any. I stopped at the station. She looked up. You move like you've worked somewhere else before this, I said. It was not a subtle opening. She looked at me for a moment and then said, most nurses have worked multiple postings. Not the way you move, I said. There's a specific quality to it. Like you've been in environments where your response time had to be short and the space you were working in was not predictable. She was quiet. I'm not asking to pry, I said. I'm asking because I've been watching you work for over a week and what I see doesn't line up with the way you're being treated, and I'm trying to understand the gap. She put down her pen, looked at me with the direct quality I had come to associate with her. Where did you serve? She said. I told her. Something shifted in her expression. Not dramatically, but a slight recalibration, a small adjustment like a dial being turned 1 degree. DEVGRU, she said. The fact that she said DEVGRU and not SEAL Team 6, which is the civilian media term, told me something immediately. Yes, I said. She looked at her hands for a moment. Then she said, I spent 4 years as a trauma nurse attached to a special operations element, before this posting. Which element? I said. She told me. I looked at her. She met my gaze without commentary. The unit she named was a direct action element that I had operated alongside on 2 separate deployments. I did not know her name from those deployments. The support staff rotated frequently, and we were not always introduced formally, but I knew the unit. I knew what the medical personnel attached to that unit encountered. I knew the operational tempo, the casualty patterns, the specific and severe demands placed on trauma personnel in that context. I knew what 4 years in that environment cost a person and what it built in them. "You've been doing forward surgical work," I said. It wasn't a question. "Among other things," she said. I thought about Carver. I thought about call someone qualified. I thought about the reassignment that had been processed as a care accommodation. "Does the ward know?" I said. "My file is here," she said. "Anyone who looked would find it. But you haven't told anyone." She looked at me with an expression that I thought later was one of the most considered expressions I had encountered in my adult life. It held several things at once: patience and a kind of quiet sorrow, and something that was not quite anger but occupied the same space. "I came here to do my job," she said. "I came here to provide good care to patients who have been through significant experiences. My prior postings are either relevant to that or they're not, and either way my care record here should speak for itself." "It does," I said. "I've been watching it." "I know," she said. "I noticed." There was a pause. Down the corridor, a door opened and closed. Somewhere outside, the early dark of a March evening was settling over the base. "He's wrong about you," I said. "I know that too," she said. It was not defensive. It was not seeking validation. It was simply the flat, accurate statement of someone who has processed a truth thoroughly enough that external corroboration, while noted, is not the source of their certainty. I went back to my bed. I lay there and thought about what she had told me and what she had not told me and what the gap between the two contained. She had been attached to a special operations element. She had done forward surgical work. She had 4 years of experience in one of the most demanding medical environments that exists, in operational contexts where the margin for error was functionally zero. And she had come to this ward, and she had done her work without announcing any of that. And she had been dismissed by a man who had looked at her and made a category decision. And the category decision had been processed through the ward's accommodation mechanisms and turned into a formal reassignment. And somewhere in her personnel file, if anyone had looked, was the record that would have made the dismissal impossible to sustain. But no one had looked. I thought about how often that happens. How often a person's actual record and the treatment they receive exist in the same system and never intersect, because the people doing the treating have decided not to look. I thought about what I was going to do with what I now knew. Carver had a visitor on Saturday. A man I didn't recognize, officer's bearing, the particular economy of movement that suggests long institutional conditioning. He came in mid-morning, stayed for about 40 minutes, and when he left, Carver seemed elevated in some way, like a level had been confirmed. That afternoon, Carver was cleared for unsupervised corridor walks. I watched him move through the ward with the ease of someone who was beginning to remember that his body was, in fact, his again. He stopped at the nursing station, spoke briefly to the nurse who had replaced Keller on his case, and then stood for a moment in the corridor looking down the ward. Keller was 3 beds away, running an assessment on the patient at the far end. Carver watched her. I watched Carver. He walked toward her. I could not hear the exchange precisely from my bed, but I could read its shape. He said something. She responded without looking up from the chart. He said something else. This time she looked up. There was a brief conversation, perhaps 90 seconds, and then he walked back toward his bed. I waited until he passed and then said, "What did he want?" Carver glanced at me. He seemed mildly surprised that I'd asked directly. "Just clarity on a scheduling question," he said. He settled back into his bed. That evening, I was at the nursing station for a question about my own chart when Keller was there, and I said quietly, "What did he say to you this afternoon?" He looked at me with a slight pause. He wanted to know why I was still assigned to this section of the ward if I was off his case. "What did you tell him?" "That my assignment is determined by ward management and I was there to care for the other patients in the section." "How did he take that?" "He said he would speak to the ward commander about the arrangement." I absorbed this. "He won't do it directly," I said. "He'll frame it as a care concern, something about disruption to his recovery environment." She looked at me. "Probably. Do you want to tell Moss before he does?" She was quiet for a moment. Then, what would that accomplish? It was a real question, not a rhetorical one. She was asking me to think through the mechanism, not simply perform the action. I thought about it. "It would put your account in the record first," I said. "Right now, the only version that exists is his. If he makes a complaint, the responding documentation reflects his framing. And if I go to Moss first? Then there are 2 accounts, and anyone reviewing the record has to weigh them against each other rather than responding to one as if it's uncontested. She nodded slowly, not in agreement exactly, more in the way of someone integrating information. There's something else, I said. She waited. Your file, I said. Your prior assignment. You said it's there for anyone who looked. Yes. Moss hasn't looked, or if he has, he hasn't acted on it. Possibly, she said carefully. If Carver makes a formal complaint, I said, it goes up the chain. The ward commander looks at it. And when the ward commander looks at it, they also look at your file. And what's in your file changes the context of his complaint. She was very still. You'd have to confirm that your prior unit is listed in your service record, I said. I can't know that from here. It is, she said quietly. Then a formal complaint from him is the mechanism that gets your file reviewed by someone with decision authority. She looked at me for a long time. There was something in her expression that I found difficult to categorize. Not surprise, not gratitude. Something more like the recognition you feel when you've been carrying a problem alone for long enough that even having someone understand the shape of it feels significant. You're suggesting I don't prevent the complaint, she said. I'm suggesting that preventing it keeps the current situation stable, I said. Which means you remain on a ward where your experience and your record are functionally invisible, and a man whose assessment of you is wrong continues to operate as if it's correct. She looked at the chart in her hands. And if the ward commander sees the file and does nothing, she said, then you're in the same position you're in now, I said. But at least someone with authority has seen the record. She didn't say anything for a moment. Then she said, I wasn't trained to wait for someone else to fix things. I know, I said. Neither was I, but there are situations where the fix is in the record, and the record needs a reader, and you can't force someone to read it. You can only create the circumstances under which they're required to. She nodded again. This time it was something different. The next morning, I found out from Moss that Carver had submitted a formal care environment concern regarding nursing staff continuity in his ward section. The ward commander had requested the full personnel files for all nursing staff currently assigned to the section. I lay back and waited. The ward had a quality in the 2 days after the complaint was filed that I can only describe as a held breath. Not dramatic, nothing visible changed. The rounds continued. The medications were administered on schedule. The corridor outside had the same sounds at the same intervals. But there was a density to the ordinary activity, a weight beneath the surface of things, that I think most of us in the ward felt without naming. Carver was unaffected, as far as I could observe. He was in the phase of recovery where the body begins to reassert itself. His color was better. His movement in the corridor was steadier. He spoke to his replacement nurse with the ease of a man operating within an environment that had been arranged to his specifications. He did not appear to be thinking about the complaint he had filed. It had been a tool, used for a purpose, and the purpose had been served, and he had moved on. I found this difficult to watch, not because I expected him to feel guilt. I don't think guilt was available to him in the form that this situation called for, but because of the disparity. He had filed a formal complaint against a nursing professional with 4 years of special operations trauma experience, and he had done it because she had noted that his breathing exercises were logged once when he claimed to have done them more. He had done it because her presence in the ward section made him uncomfortable in a way he had decided was entitled to institutional redress, and he would never know what was in her file. That was the part I kept returning to. On the second evening after the complaint, Keller came to do the late chart review. She was alone in the ward for a few minutes. The other nurse was down the corridor, and I was awake. What did the commander say? I asked. She came to my bedside. Nothing yet, she said. The review is still ongoing. But she's seen the file? I believe so, I nodded. She looked at me with the direct quality that I had come to understand was simply how she looked at things, without performance, without the social smoothing that most people apply to direct eye contact. Can I ask you something? She said. Yes. Why did you engage with this? She said. You're a patient. You could have watched it happen the way the others did. You're here for 3 weeks and then you go home. This isn't your ward or your career or your problem. I thought about the question seriously because it deserved a serious answer. I've spent 11 years in environments where the quality of the person beside you can determine whether you come home, I said. In those environments, allowing a wrong assessment of someone to go uncorrected isn't just unfair to that person. It's a failure of the system that everyone depends on. This isn't that environment, she said. No, I said, but the principle is the same. You're good at what you do. You've been treating patients in this ward with the same precision you used in the field, and a man who doesn't know what you are has spent 2 weeks treating your performance as inadequate. And the system was processing his framing as if it were accurate. That's not a small thing." She was quiet. "In my experience," I said, "the cost of allowing wrong assessments to stand is paid later, and usually by people who didn't author them." She looked at her hands. "It's not the first time," she said. "Coming from that assignment to a standard ward, there's always a," she paused, "adjustment period for other people. There's a specific kind of patronization that happens when people don't know your background and you've decided not to announce it and you're doing the work at a level they can't fully account for. It's not always malicious. Sometimes it's just," she searched for the word, "lazy assessment," I said. "Yes," she said, "that. But this was more than lazy," I said. "Yes," she said again, more quietly. We sat with that for a moment. I thought about what it had cost her to come to this ward after 4 years in the field. The specific psychological adjustment of moving from an environment of constant consequence to one that was, comparatively, controlled and predictable. The way that background doesn't disappear when you change the setting. It simply becomes invisible to the people around you, which creates its own kind of isolation. And then to have that invisibility exploited. To have someone look at the surface and decide the surface was the whole picture, and to have that decision processed through a formal mechanism and turned into a care accommodation. She had carried that for 2 weeks without outward complaint. I had been trained to assess load-bearing capacity under pressure. The specific kind of strength required to carry something that quietly, for that long, without performing it. I did not have a technical term for it. But I recognized it completely. The ward commander came to the section on Tuesday morning. Lieutenant Commander Hayes was a woman I had seen once before in passing, brief, precise, the manner of someone who has learned to make decisions efficiently because the alternative is decisions that don't get made. She came in with Sergeant Moss, went through 3 beds, and then came to Keller, who was at the chart station. They spoke quietly for several minutes. I could not hear the content. I could see the quality of the exchange. Hayes asking something, Keller responding without hesitation, Hayes making a note. Then Hayes went to Carver's bed. I watched that exchange more carefully. Carver received Hayes with the calibrated respect of a senior enlisted for a commissioned officer, present, attentive, but with the underlying assurance of a person who believes they are in an advantageous position. Hayes spoke. He listened. He spoke. She nodded twice and made another note. She left the ward without looking at me. What happened over the following week was not announced. It was not dramatic. It had the specific texture of institutional adjustment, quiet, procedural, made legible only through its effects. Keller was reassigned back to Carver's section on Wednesday, not to his direct case. He had a nurse he'd apparently been cooperative with, and that assignment was maintained. But she was present in the section, and she was no longer restricted in her movement through it. On Thursday, I heard Carver ask Moss a question about the reassignment. I couldn't hear Moss's exact response, but I heard the tone, the specific careful flatness of someone delivering a decision that is not open for discussion. Carver was quiet for the rest of the morning. On Friday, something happened that I had not anticipated. Hayes came back. She came directly to my bed, which indicated that I was the purpose of the visit rather than a stop on a general round. She said she understood I had spoken with Nurse Keller about the care environment concerns that had been filed. I said I had. She said she wanted me to know that the review had been completed and appropriate adjustments had been made. She said it in the clipped, professional way that communicates that the statement is both complete and an ending. I asked, carefully, if the nursing staff's service records had been reviewed as part of the process. Hayes looked at me for a moment. "Standard reviews include full personnel files," she said. "And that was informative," I said, another pause. "The ward's care assignments are now appropriately structured," she said. It was not a direct answer. But it was, in context, the answer. What she was telling me in the bureaucratic language of institutional closure was that someone had looked at the file and what they had found had changed the calculus, and the calculus had produced the outcome I was seeing. She left. That afternoon, I was in the corridor and passed Carver coming the other way. He did not say anything. Neither did I. We had never spoken about what had happened between his bed and Keller's assignment and the formal complaint. It had occurred in a register neither of us had directly addressed. He looked at me as we passed with an expression I had difficulty categorizing. Not embarrassment exactly. Something with less self-awareness than embarrassment. more like the look of a man who has encountered a piece of information that doesn't fit his model and has decided to file it rather than revise the model. I did not expect the model to change. That is the honest part of this story that I have to include. The mechanism worked, in the limited sense that the record was corrected, and the care assignment was adjusted, and a formal complaint was resolved in a way that reflected Keller's actual qualifications. But Carver did not learn anything that he retained. He was discharged 4 days after the adjustment, and he left the ward in the same relationship with his own authority that he had entered it. The institutional record was correct. The man was unchanged. I have thought about what that means, and I have not arrived at a clean answer. Sometimes the system works the way it's supposed to work, and the individual within the system is unaffected by the correction. The two things coexist. They do not resolve each other. Keller continued her rounds. She moved through the ward with the same economy, the same precision, the same quiet competence that had been present the entire time and had required a formal complaint and a personnel file review to be made visible to the people with authority. That is the part I find hardest. I was discharged on a Friday morning. The process was similar to the one I'd observed for other patients. Forms, instructions, a brief conversation with the attending physician about the timeline for resuming physical activity. Moss shook my hand at the station. The ward had the particular late morning quiet of a place that exists in cycles, that receives people and processes them, and releases them and receives the next. Keller was not there when I left. She was in the back section with a patient who had come in 2 days prior, a ranger with a significant leg injury who was going to be there for a while. I left a note at the station. I did not write much. I said that I had observed her work for 3 weeks, and that it was exactly what it needed to be, and that I thought she should know that. In the corridor on the way out, I passed a newer nurse who was reading a chart, young, efficient-looking, 2 weeks in by the look of her slight over precision with the board. She reminded me of no one in particular, and I thought, she's going to develop into something good, and some of the people she cares for will recognize that, and some will not. That is always how it is. I thought about the tattoo, the unit insignia on Keller's inner forearm that I had finally seen clearly when she'd rolled up her sleeve during a difficult IV placement on the patient at the far end. A small, precise mark, the specific seal of the element she had named. She had not shown it. She had been doing something with her hands, and it had become visible, and she had not hidden it. It was simply part of what she was, and it had been there the entire time, and the people who needed to know had eventually known. That is, I think, the whole of what happened. A person with a full record was dismissed by a person who didn't look. The record found a reader. The adjustment was made. The man left unchanged. The woman continued her work.